The cornerstone of resuscitation is improving perfusion, often by improving cardiac output. In this video, we'll go through how you can measure cardiac output with ultrasound. I'm Dr. Alex Estelle, and this is SonoCare. Cardiac output is the volume of blood pumped by the heart each minute. It is equal to the volume of blood pumped with each heartbeat, the stroke volume, multiplied by the heart rate. The normal range for most people is 3.5 to 5.5 liters per minute. A cardiac output less than 3.5 liters per minute usually suggests a problem with pump function or filling, while an increased cardiac output suggests increased metabolic demand. While an elevated cardiac output occurs naturally in the setting of exercise, in a patient care setting, this usually results from an infection or distributive shock state. To estimate stroke volume, we imagine that each heartbeat ejects a cylinder of blood. The area of the base of this cylinder is estimated using the LVOT diameter, measured in the peristernal long axis or mid-esophageal three-chamber views. We want to make sure we're aligned through the middle of the outflow tract. We should see both valve leaflets opening and closing throughout the cardiac cycle, the sinuses of Valsalva, and the proximal aorta. We may need a little bit of clockwise, counterclockwise rotation and or tilting of the probe to ensure our alignment. Once we're happy with our alignment, we zoom in on the LVOT and freeze in systole with both valve leaflets open. We then measure from inner edge to inner edge, approximately 5 millimeters below the level of the valve. We need to be careful when making this measurement. This value is squared in our final calculation, so any error we make now will also be squared. The average for most people is approximately 2 centimeters. So if you're getting a value that's far off from that and your patient's not either very large or very small, you'll want to recheck your alignment and take several measurements to ensure accuracy. The height of the cylinder of blood is acquired by measuring the velocity time integral. From either an apical 3-chamber or apical 5-chamber view, we align ourselves with the direction of blood flow through the LVOT and place our pulse wave Doppler gates just below the level of the valve. It's important to note that we lose signal for every degree we are off from the direction of blood flow, and it's not recommended that we take a signal when there's a greater than 20 degree margin of error, as we will markedly underestimate the VTI. When we're happy with our alignment, we'll sample the Doppler signal and should see a series of smooth parabolic waveforms. We can freeze the clip and trace along the outer edge of the waveform to determine the VTI. Sometimes, changing windows, for example moving from an apical 5-chamber to apical 3-chamber view, can be helpful to find the best alignment for Doppler interrogation. For best results with our VTI measurements, we should take multiple tracings to account for stroke volume variability. This is particularly important in patients with atrial fibrillation where there's inherent beat-to-beat variability. In this setting, it is recommended we take 5 measurements and average them. Once we have our LVOT diameter and VTI measurements, we can estimate the volume of the cylinder of blood. We assume that the LVOT is perfectly cylindrical, have the diameter to get a radius, and estimate the area of the base of the cylinder as pi r squared. We then multiply that by the VTI to get our stroke volume. Multiplying our stroke volume and heart rate gives us our cardiac output in milliliters per minute. Cardiac output estimation is particularly helpful in assessing for the type of shock present, say in differentiating hypovolemic and distributive shock, where the former has a low cardiac output and the latter has a normal to elevated cardiac output. It's also very helpful in the titration of inotropic agents, as we can repeatedly measure cardiac output to see the effects of inotropes on the heart. I find this one of the most helpful POCUS skills in the acute care setting, and I trust you'll find it a valuable addition to your patient care toolbox. I hope you found this video helpful. Now get out there and scan.